Town, Connecticut, and she actually traveled a fair amount in her educational journey. She received her MPH from Tulane University in New Orleans, and then her MD degree from the University of Rochester in Rochester, New York. She did her general psychiatry residency at the Baylor College of Medicine in Houston, Texas, and then moved up to New England to do her child and adolescent psychiatry fellowship at the Cambridge Health Alliance and Harvard Medical School system. After finishing fellowship, she remained on as a faculty member in the Harvard system and worked as initially a staff attending psychiatrist and then as a medical director at the Cambridge Health Alliance in Cambridge, Massachusetts. She is a well-respected child psychiatrist and a renowned educator. In fact, she joined Maine Health back in 2018 as a faculty member and immediately won the Attending of the Year Teaching Award. She teaches across the spectrum of trainees, from medical students teaching in the Tufts University curriculum about the basics of mental illness and psychotropic medications, as well as teaching fellows and residents in psychiatry. And she has been a co-investigator on a variety of studies that have tried to improve access to care, particularly for adolescents and children. And she has published a fair amount as well on a variety of topics, including mental health with gang members and other interesting looking articles. And she is now the lead for the state of Maine HRSA grant to improve access to children and adolescents in the primary care setting by developing a robust instructional program for primary care providers in Maine. So, Dr. Mayhew.
Thank you very much. So I'll have to apologize because I've got some technical difficulties, as those of you who came on initially saw. So I've got 3 screens. And in order to actually get a good view of my screen to see the slides, I actually have to look at one of the other 2. So I will keep looking back and forth. So, I really wanted to kind of use this opportunity and I apologize to those of you who've already seen me this week. I hope it's not too boring, but I wanted to use this opportunity to kind of talk about these child psychiatry access programs that are across the country and kind of what we're trying to institute here in Maine. I do have a co-physician lead who's at Northern Lights, Joshua Newman, and Jesse Higgins is a nurse practitioner. So I want to make sure to give them credit on their part of this project. But really wanted to use this opportunity to give you in pediatrics a sense of like what's happening nationally and kind of what we're trying to do here. And can I just change slides? Let's see. Oh dear. Can you all see the next slide? I just want to make sure before I go forward. So
Yes.
Yeah. Okay, great. Because I can only see it on one screen. So conflict of interest. I mean, I don't get anything out of the grant other than it pays part of my salary and I get a lot more work, but I did want to say that I am part of this grant process. So our learning objectives for today, I want to describe to you the kind of MCPAC model because that's the model that a lot of these child access programs are based on. Talk to you about some of the key components that you'll see across the nation, looking at a couple different programs, and then understand how we are trying to institute this in Maine, both in Maine Health and in the state, and what kind of projects we're working on that you might come into contact with in pediatrics in your day-to-day practices. So this is from the ACAP website, actually, just kind of giving a sense of where there are practicing child and adolescent psychiatrists in the country. Ironically, you will see that we actually, compared to the rest of the country, have a decent amount of child psychiatry. meaning that we're high shortage instead of severe shortage, which isn't that great. And then on the right is a map of Maine, and you can see obviously where we are located or where there's the most child psychiatrists. I would say that you guys in pediatrics would probably feel like there's not enough, but compared to the rest of the state where there's places where there are 0 child psychiatrists, we're actually pretty well endowed. Sorry if this is a little blurry, but I just wanted to give you a sense of looking at where there's child psychiatrists across the country. Interestingly, DC seems to have the most child psychiatrists. So I guess if you're a kid with problems and need to see a child psychiatrist, that's where you should live. Looking where Maine is compared to other states, you can see that we're kind of in the middle. Again, looking relatively good compared to the rest of New England. But if you look at some of the other states like Mississippi, South Dakota looks to be the worst. There's really a pretty wide range of child psychiatrist availability in different states. These are just some statistics again from the ACAP website about the population of kids under 18 in Maine, how many child psychiatrists there are available. And then the percent per 100,000 is 24 child psychiatrists per 100,000 in Maine. And the average age is 52. So just to keep on the horizon that there are people that currently see kids who are going to retire. I don't know about you, but I've had this experience recently where I've gotten a lot of people referred to our clinic because either nurse practitioners or people in the community are retiring. And then if you look on the table on the right, that is the actual, all the different counties in Maine and how many child psychiatrists there are per county compared to the population. So this is no news to anyone. There's a severe shortage of psychiatrists nationwide. I talked a little bit about this on Monday, so I apologize for those of you. It's a little bit of a repeat, but nearly 1 in 5 kids have mental, emotional, or behavioral problems, and only 20% of those kids are going to receive care from a specialized mental health provider. As we know, 50% of all lifetime cases of mental illness start by age 14, and 75% start by age 24, which is why it's so critical for us to be working with this population. And then 70% of youth in the juvenile justice system suffer from mental health disorders. There are approximately 8,000 practicing child and adolescent psychiatrists. That number changes depending on the year and kind of what you're considering, whether you're considering trainees or people that are fully licensed and attending, practicing in the community. And then again, the rates of range by state, as I showed you earlier, 1 to 60 per 100,000. And the median is actually 11 per 100,000. So you can see that we with 24 per 100,000 are actually doing better than a fair amount of states, which isn't saying a lot, unfortunately. So I wanted to kind of think, I'm talking about child access programs, but I really wanted to take this opportunity to talk to you about thinking about the whole system, because there's really a lot of work we need to do in mental health to make sure that we're treating kids and their families adequately. So what we're really talking about is primary care, obviously, and access to child psychiatry for primary care and consultation in primary care. But really, there's a lot of work that needs to be done across the system. We need to have more child psychiatry access in the emergency department. We need to have more inpatient beds. We need to have better community education. I know a lot of the pediatricians and family practice docs are doing work with schools. I mean, we also in child psychiatry would like to be doing more work with schools about preventative measures, trauma-informed teaching, making sure that teachers, who get a lot of training on actually teaching, but very little training on classroom management. I can say that as a daughter of a person who taught school for 35 years, but really just kind of helping them learn how to manage kids that are having problems in school. There's a dearth of mental health services in the community. There's not enough residential care. So I'm just, pointing out that we're talking about a very small piece of a much bigger project. Even when we're talking about just child psychiatry access programs, we have to think within the bigger need of society and treating mental health in kids. So some of the challenges that you all face thinking about treating kids in primary care is that, most kids are going to come to you. They're not going to come to us because they don't want to go see a psychiatrist, even if there is a psychiatrist available. And there's a lack of providers. So most people with issues with psychiatric issues are going to first go to primary care. Primary care often has a gap in training and knowledge in detecting, diagnosing, and treating psychiatric conditions. I mean, I'm not a pediatrician, so I don't know exactly what training you all get. And I think there's been a robust change in trying to help you all do better work within your practices, but it's still difficult. You have a lot of other things to manage besides also learning those skills. And after the fact that people don't often have resources to address these conditions, and then they can't refer. So you may be able to identify what's going on, but you say, okay, now I need to see a therapist, but where's the therapist? How do I find them? There's variation in insurance coverage. So it's interesting. I have a lot of conversations with pediatricians in my role in the referrals to our clinic, who are surprised to learn that the behavioral health carve-outs don't necessarily cover our services, that they may have Cigna that will cover them in primary care, but that they will not actually cover our services. And so that can be very confusing for people. And then lastly, there's a lot of administrative barriers that hinder the access to psychiatric information. As you know, we this week went to Epic. It is out of the love for primary care that I'm doing this talk right now, because my head is exploding from Epic. But you know, we've been in Meditech all this time, so it was not even the same medical record. And it makes very difficult for primary care to feel comfortable saying, okay, well, you've done what you can with this person, and now give them back to me and I'll manage it, because God knows if you can reach a child psychiatrist later. This is a slide I showed on Monday, but again, just to think about it a little further, this is again from ACAP, the child psychiatry parameters, thinking about what the model should be for managing conditions with primary care. So you see it's a stepped model with primary care taking more care of low need conditions, kind of regular temper tantrums, separation anxiety, that kind of stuff, low level depression and anxiety to be able to manage that mostly yourselves, ADHD. And then kind of as things get more complicated, that we in child psychiatry would be more and more involved. I have to say that one of the barriers to this is just making sure that we have good communication so that we all know what's going on with the patient and feel that things are being handled smoothly. I have to say from my end, and I know my colleagues have similar feelings, I often will hold people in child psychiatry because although they're stable at this point, I'm not sure if the pediatrician is going to be comfortable managing them. How am I going to communicate with them if things go awry? Because oftentimes things will be stable for a while and then will become destabilized, and just trying to figure out how to manage that from my end. So let's talk a little bit about these child psychiatry access programs. What is it? It's a formal program that's been made to facilitate a more timely consultation between primary care and child psychiatry. So these programs are really made so that if you are seeing a patient, you have a question, that you can reach out to a child psychiatrist and talk to them about what you see and get some guidance. It's supposed to also be, most of these programs will also have some support for identifying community resources to help primary care manage them after the consultation. It also oftentimes includes education, so lunch and learns, which you guys are familiar with, ECHO, which we've also been using here at Maine Health, and then learning collaboratives. And these programs also provide funding for different programs, and the funding can be very different. Each of these programs in different states gets funding from different combinations. It can be state or federal funding, insurance funding, and private funding. So let's start with MCPAP. This is kind of the jewel. I said the holy grail. I took this picture from Sandy Fritz, who some of you I'm sure know, who was instrumental in kind of doing a similar program here in Maine. I will say that the grant that we currently have is based off of her original work and a lot of the grant writing that she had done previously. So she still lives on, even though she's now in Colorado. So MCPAP was started by a pediatrician in conjunction with the University of Massachusetts Med School in Worcester in 2003. They had a pilot program, and then the program was picked up by the Department of Mental Health. So the AAP in Massachusetts, the Mental Health Task Force, really got on board and promoting this program. And then in 2004, the DMH and the Behavioral Health Partnership adapted this program statewide. So initially, this program was funded with a legislative appropriation. So it was actually a line in the budget, which is how it was able to be funded. And their state law in Massachusetts now mandates collecting funding from commercial carriers. So basically, insurance companies have to pay a fee in order to support this program. In Massachusetts, the fee currently is $2.33 per person per year. And the estimated cost in Maine would be $2.10 persons per year to fund a similar program. So this is just some stuff off their website. They have a great website. They have a lot of resources. They've divided the state into multiple regions. So you'll see by looking in the middle that there's a Western Central region, an Eastern region, and a Boston South and Boston North, and they're all covered by different hospitals. So Bay State and UMass Memorial cover the Western and Central Maine. Boston South is Boston Children's, McLean and Tufts, and then Boston North is Mass General and North Shore, which is also part of the Mass General system. And you'll see that basically there's a number that you can call if you're in one of these areas, and then you will reach someone. Having known people that were kind of involved in staffing this, normally what happens is it's split up between the different psychiatric providers, and that they can place a phone call, and then they can decide if there's needed to be a face-to-face consultation after the phone call. And they do have care coordination to kind of help find resources afterwards. And you see that they can actually respond to these calls within 30 minutes, which is pretty amazing. Some other things that are great about the MAYHEW program is that they've had the funding and they've been around long enough that they've also developed some fairly good diagnostic resources. So I encourage any of you that are looking for resources to look at their website. They have some great stuff that's specifically geared for primary care. And then you see on the right that you actually can enroll in the program, and they do that because they're trying to gather data and then to make sure that people are connected to the right team that's covering whatever part of the state. And really the goal of that is not just to get you somebody to talk to on the phone to help you when you're having an issue, but is also to kind of create relationships with particular psychiatrists so that when you have a problem later that you feel comfortable reaching out to that person and getting a consultation. Because as you know, I'm sure you have in your own practices, as you get to know specialists over time, or as we get to know primary care docs, you start to develop an understanding of what people are good at, what they need help with, kind of, and just feel more comfortable kind of being more open about what your needs are. So this again is from some of the stuff I talked about on Monday, but it's worth repeating. So there's been a fair amount of research that they've done out of the MAYHEW program, and they've found that 28% of these initial consultations, meaning these phone consultations, led to a face-to-face consult, which means that the vast majority of these phone consultations did not, which is a huge time saver for psychiatry and also for pediatrics, because you don't have to wait 3 months for your patient to be seen. You can actually start treating them in the moment. And that actually, as this relationships developed, primary care agreed to manage follow-up for 50% of the patients that were seen. So again, from the perspective of both psychiatry and pediatrics, it's a win-win because we get to see the more complex patients and you all feel more comfortable kind of managing these patients in your practice. The ability to get a consult from child psychiatry went from 8% in the beginning of the program to 80% currently. So the fact that you can get a consultation relatively quickly improved over time. And it says 28 states where this model's been adopted. I think it's actually more like 30, 31. So there is a collaborative, which we are a part of, a national network of child psychiatry access programs, which we are part of with the grant that we have. And basically, this particular route is about telepsychiatry, but we have listservs and coordinate and discuss different aspects of these models and how to implement them in different states. There's often questions from different states about how things are being implemented in their state. They will send out videos that they've created or talk about how they're interacting and trying to get primary care enrolled in their programs. It allows for kind of sharing of information about how they're coordinating, kind of like how they're getting access to psychiatry for consultation for pediatrics, what their integrated clinicians are doing, giving treatment guidance for PCPs. I mean, I'm giving you the MAYHEW website. If you look at other websites, there's a lot of sharing of information going on. Ultimately, a lot of these programs in the collaborative care model want to move more from just this kind of one-off phone consultation to really be more integrated with the different practices and actually do some panel management, being able to identify early issues, working with the integrated clinicians so that they, in the practices with primary care and psychiatry, can kind of be able to identify people early and kind of help them before they get to a place where they have a psychiatric diagnosis. There's been a fair amount of research that's shown that having these kinds of programs really improves mental health outcomes. And although the payment model with the ACO and the creation of the ACO was that eventually we were going to go to population-based payments, that hasn't happened quite yet. And so that funding for this program in particular remains a particular challenge because a lot of the services that are needed to kind of support these programs and make them work are not billable. And so figuring out funding models to continue to have these services and make this model work are crucial. So this is just kind of talking about the pediatric mental health care access program, again, which is what we're a part of and where our funding comes from through DHHS and CDC. So this is just kind of looking at different models across the nation. And then this on the right-hand side is looking at the screening and treatment, which is a coordinated effort. So again, the first program was through MCPAP, and then these are some of the other states that are currently involved and that have kind of more robust programs. New York, Washington, Oregon, Connecticut have some robust programs. And then in 2016, they really started to push forward grants from the federal level to promote integration with pediatric primary care. And it really have put a fair amount of funding towards it at $9 million. I think, and then Colorado's program was funded in 2018, which is where Sandy Fritch is now. But for us that are involved with these programs, I think that, we're very excited about it and kind of what the possibilities are, but we do obviously have some worries about the fact that this is a grant model and what's going to happen if there's a different priority that comes forward in the future, and then there's no longer the funding to support this program from the federal level. So this is just kind of looking at the current networks. As you can see, there are certain models that are more robustly created. There are states that don't have models yet. And then there's places that have full programs or partial programs. I think Kate Herlihy, who maybe is on this call or maybe she's busy, and I went to a conference actually almost exactly a year ago at Nationwide that was sponsored by the Children's Hospital Association, kind of looking at the very same issue. So there's lots of different organizations that are looking at how do we increase access to mental health care for pediatrics and for children in pediatric practices. So currently, if you're involved with these grants, which these are the states that are involved, there's some core requirements in order to be involved. You have to have gotten grant funding through the maternal child health part of DHHS. You have to have an advisory committee, which some of the people in this department are on, as well as other practices across the state. We have to do a needs assessment and kind of look at what the needs are in our state, report the metrics back to Congress about what we've discovered, and then try to work on enhancing current telehealth services. Obviously, that has taken off with the pandemic, one of the few bright spots that have happened for us because of the pandemic. We also do create work plans, which is something that we're currently working on with our partners at the state and Northern Lights. And there's a lot of evaluation metrics about trying to figure out what works and how we can show that we're actually making a difference. So I'm just going to look briefly at a couple different programs just to show you kind of what's happening. And the joke about my title to this series is that there's not really a secret sauce. Like the secret sauce is kind of similar at different places. And I think that if you want to say that there is the secret sauce, it's really in the details about getting the programs up and running, coordinating across different agencies, and trying to figure out how to reach all these different practices. I mean, that's really where the secret is, because each state obviously has different needs and has different relationships, and trying to set up that system is quite complicated. So anyway, this is Oregon's program. Opal is the name of it, which is cute. Oregon Psychiatric Access Line. Like a lot of these programs, they have call center hours. We are not at that place yet in Maine, but hopefully we'll get there someday. Their hours are 9 to 5, Monday through Friday, except major holidays. It is not a walk-in clinic or referral site. It is really for providers, and it provides only phone consultation. So this program mainly is a phone service. They have not gotten to the place where they've got all the face-to-face stuff some of the other programs have, but they're kind of more in the beginning stages. This is Washington's program, Washington State. There is also an Alaska partnership. There's, I don't know if any of you had looked at either training or out from that part of the country, but there's kind of a 5-state collaborative that does a lot of work together. So I think that that's why Wyoming, Alaska, Washington, I think Idaho often have that work together. So anyway, they have also supports for primary care. You can ask questions. They do have social workers that can help with resources, which is great. They have multiple different options. So if you look at on the right on their menus, they've got school partnerships. They've got referrals for kids and teens. There's just kind of more robust resources because their program is better funded and it's been around a little longer. A lot of the stuff that you'll see, which is interesting if you ever take any time to look at the programs across the states, you can see the programs that have more academic support, support from insurance companies, or just have been able to get private support, do have more robust programs. This is Connecticut's program. It's called the Access Model. Similarly, they can do a phone consultation within 30 minutes. They can help with finding behavioral health services, and then they can do training and education. So you see there's a lot of similarities between these programs. It's just different programs can offer more. They are able to refer to a program coordinator or a peer support specialist, which is great. And then they can do some face-to-face or telephone consultation, and they can, this program is able to refer to the team psychiatrist to do face-to-face consultation, which is kind of more like McPap's model, that you can get to that kind of service. So I'm going to spend a little time talking about Colorado's model, just kind of in honor of Sandy Fritch, since she was the one who did a lot here in Maine. So she's currently working as a physician lead for their program. Again, you'll see that there's some similarities. There's the map of Colorado and kind of like where their dearth of services are. It looks like they have a lot of counties that have no services, and just some counties that have only a high shortage. Similarly, they do a phone consultation. It is payer blind. They do a little bit higher age ranges. Some of the other programs I looked at are up to 18 or 19, but they actually go up to 25, which kind of to me makes sense for pediatric practices, since a lot of you do see kids up until really their brains are fully developed at 25 years old. They also have a care coordinator. They have a lot of educational resources, some of which I'll show on the next slide because I thought it was interesting. They're kind of like how they've mapped out their 4 years of funding. They do face-to-face or telehealth consultations with difficult diagnoses or treatments. So that's a great option for providers. And then they do have a toolkit of screening tools. McPap also has some of that. They offer screeners of different kinds of screeners they would offer for different kinds of diagnoses. So the requirements, I haven't talked a lot about what these programs require of participants. So there is a requirement of a sign up or orientation for Colorado, and we have a similar process here, or will be, as we roll this out to different practices. There is a survey that has to be done. It looks like it's a 5-minute survey, and then they do require 4 to 6 hours per year of education. I will say that for us, we also will be trying to figure out a way to have screenings done within primary care. Maine Health is really well positioned because a lot of these screenings are available through Epic, and we'll be able to kind of mine that data. It's going to be a little more challenging for the practices that we're dealing with that are off of Epic. And I'll talk a little bit more about how we're going to roll out our program across the state. So this is our educational series. I just want to spend a minute looking at this. As you could probably guess, these are pretty common concerns that we get consulted with all the time. I'm sure that you in primary care recognize all of these concerns. I think it's nice the way that they've laid it out so that you can kind of see where you're going. It's hopefully we will get to this point with our trainings. That's kind of what we're aiming for. We at the state level have just come up with our first year worth of trainings and are working on kind of subsequent years. I mean, really, from a psychiatric perspective, I mean, yes, some of it is important about giving some clinical pearls to help you all in primary care, but it's also a question of using these trainings to kind of enhance our relationship and your comfort level with handling some of these conditions. This is Michigan's program. Again, similar ideas as far as like what they have available. They also can do phone consultations. They can set up scheduled telepsych visits. Some of the things that I like about their program is they're talking about outcome measures that they're tracking. So they actually are tracking whether or not people are appropriately prescribing psychotropics, whether ED visits are being reduced by this program, hospitalizations, whether there's less hospitalizations, kind of like looking at what the PCPs have learned, and then whether or not people are using other interventions that are more appropriate versus medications. I know that one of the goals we have is helping primary care understand when medication is appropriate and when other interventions are appropriate. And I think that you guys already have a good base of that, but just kind of helping deepen that knowledge so that you don't feel pressured by families and patients to give a medication to someone when really it's more about therapy or other interventions. So this is the part where I get to the challenging side of this. So I'm using this example of talking about Michigan's program, but it's a similar theme across all these child psychiatry access programs. Is funding is a real challenge. So the way that they manage it currently is they charge $275 to the clinics involved with the program in order to have an initial visit. And then the clinics can send that charge to insurance companies for reimbursement, which is great. So that will pay for the face-to-face with the psychiatrist. However, it does not cover any of the other services, which in many ways are the crux of the program. So it will not cover case management. It does not cover any coordination between PCPs and psychiatry. It does not cover the coordination of the telehealth visit. So, if you've had a phone consultation with a psychiatrist and you both agree that you need to have some kind of a telepsych visit, that takes a lot of work to coordinate. And so that will not pay for that. It doesn't pay for someone to coordinate getting connected to community services. So if you decide that somebody needs CBT, then who's going to be the person to coordinate that? And it also doesn't pay to support patients and families, because this is confusing for a lot of people. Like, why am I seeing this person versus via telepsych? Is it somebody I'm going to see again? Like, are you going to manage my medications? It's confusing. And so somebody actually has to do the work to cover that. And, currently a lot of that funding is covered in grants, but the question is, how are we going to fund this in the future? As I said, the telepsychiatry consultation is billable, but the other costs are not covered. And, not only is the care provided by the care management expensive and needs to be covered, but the actual evaluation itself is quite lengthy. I know that Dr. Ed Bender is now doing consultations within as an integrated clinician. And my guess is that pediatrics wonders why it takes them so long to do these evaluations. It's because it takes a long time to do an appropriate evaluation. And so to do a good evaluation, you have to have, time to talk to the parent, you have to time to talk to the child, you have to talk to other caregivers, you have to call the school, you have to talk to primary care. If there's any agencies involved, you have to talk to them. All that data gathering takes a lot of time. And so if you have a robust system, a child psychiatrist can depend on an MA or a nurse or integrated clinician to gather some of this information, but that all takes time and money. Somebody has to coordinate the technology, like I mentioned earlier, and coordinate all these services. Another issue is that insurance may not accept the fact that a medical and psychiatric provider have billed on the same day. So even if you manage to do a e-consult like we're working on with pediatrics, where we can actually see someone in a televisit while they're with their primary care provider, insurance doesn't cover that. So even though it makes the most sense from a clinical perspective, you can't get it paid for it. And so how are you going to do that? And then phone consultation currently is not billable. We as a department, even before when this grant came around, we have a mechanism. So there's 5 of us currently, child psychiatrist attendings. And so we all act as what we call a doc of the day. And so most of you probably haven't noticed, but now we'll probably get inundated with calls. But on the referral form, people can call within 9 to 5 and talk to one of us and get help with a current patient in a situation that you're dealing with. I would say it's interesting. We don't get a ton of calls because I think most people aren't aware of it, but I've answered 2 calls this week, one from the ED and one person from Central Maine. But, we've decided as a department to do that service. That service is not paid for, and it's on top of our regular work. Part of the benefit of this grant is it has given me the time to really think about some of these issues and try to forward some of the work we're doing both within Maine Health and across the state. But if that money wasn't available, it would be very difficult to even have the bandwidth to think about these issues. So different states have come up with different funding solutions, which I'm going to talk a little bit about. Really, at this point, until the ACO model is really fully adapted and we are getting paid as organizations based on populations, it's kind of a piecemeal approach. So either care management has to be billable by itself, either through insurance or bundled services, something, as part of peer, and I don't know if the peer clinicians are on this call or not, but I know Sarah Lynch is very heavily involved in trying to figure out ways to get bundled payment for our services in peer, because it's an expensive program. We're currently grant funded, but in order to take care of families, run groups, have case management, have vocational support, which is what we all have through peer, the early psychosis program, it's expensive, and we have to figure out a way to pay for it. There are considerations, again, for reimbursement codes for phone consultations, which I know the department's working towards to try to get funded in conjunction with Project CORE and other academic institutions across the country, but currently that's not paid for. We have been really lucky to have telehealth really be up and running. I mean, here we are, we're on a Zoom call doing a talk about integrated care and access services, but we need to make sure that this continues to be supported and that the funding does not change, especially in a statewide like Maine, where I have patients from Fort Kent that I see regularly, which I would not be able to see if I could not see them through telehealth. Ideally, we would like to get to a place where we really are doing co-management. And so, like, for example, we would be doing virtual chart rounding, maybe meet once a week or once a month with the primary care doc and with the integrated clinicians to look at panels of patients and manage them that way. So we're not just having to do things one by one. So this information comes from Sandy Fritz. She did a presentation recently for the different programs across the country, talking about some of the discussions that different programs have had about how are they managing to fund their services, and what's different about different funding sources and how you can make sure these programs are supportable. So they did some semi-structured interviews before the pandemic between December 2019 and February 2020, input from these various states and the District of Columbia. They looked at what's the history of the funding in these different programs, what's their current funding stream, whether it's commercial or Medicaid insurance, what are the components of the programs that they have, what's their vulnerabilities, and then what are their reporting requirements to get funding. So, different states have used different methods to leverage funding. You can see some of the examples here, community activism in Massachusetts, Washington, Oregon, getting community stakeholders involved, using the AAP, ACAP. I love my, parent organization, but we're small compared to the AAP. So really needing to get larger organizations, the family practice organization, to kind of support, using lobbyists from hospitals to try to get the state to be involved, and insurance companies. Other states have worked more on the legislative side, so working with kind of quote unquote mental health friendly legislators or governors to get laws passed or to get line items inserted, using different mental health information, so like state suicide rates, to highlight the program to get larger government support. And then in states like Texas or Connecticut, different mass shootings unfortunately have worked to get some support behind these different efforts. This is just looking at different payer sources for the different states. As you can see, some are using Medicaid, some are using line items, some are using legislation, some are getting state funding. And really, it's just a variety of different funding. And so it's very piecemeal. And so really, it would be great if we could get to a place where all the different stakeholders involved could agree to fund this, so we could really concentrate on the work and concentrate less on trying to figure out how to make sure that we last from year to year. So there's a lot of vulnerabilities to the funding and the current methods that we're using. If there's a change in the legislature or the governor, there can be a rapid change in priorities. So a line item that existed 1 year may no longer be there. Budget cuts is a consideration, especially now with the pandemic, like what's going to happen next year or the year after. There's been a lot of talk about, maybe the budget cuts won't be as bad because the revenue may not have been as bad as originally anticipated, at least for our state, but that still is a consideration what's going to happen. One concern that isn't really highlighted in some of these other parts of the talk is that, sometimes it's difficult to engage the primary care doc. So like if we in child psychiatry don't have a relationship, primary care doesn't really know what they're doing. We have an example even in this state that there's been a service through the State Psychiatric Association, but it isn't really well utilized because people don't know who's on the other end of the phone, how to access it, where it is. So you really have to kind of promote these services to show value so that the states can see why this is important and why we need to keep on top of it. So trending interests, so like thinking about the opioid crisis, school mental health shift funding priorities. And so just thinking that makes a vulnerability. Politics, which I don't need to go into, I'm sure you can think of your own examples, and then mental health stigma, obviously. So I wanted to highlight this program just for a minute. So we went, as I said, to nationwide in Ohio about exactly a year ago to go to the Children's Hospital Association conference. And we're really impressed by the work that they were able to do there, largely because Big Lots in Ohio has pledged a lot of money to support mental health. This is their mental health program. It's called On Our Sleeves. They have a lot of different information, and they have a lot of good information on their website. There's billboards everywhere. So they really have spent a lot of money, time, and energy to make this a priority in Ohio. This is the pavilion that was built. In 2016, Big Lots as an organization committed $50 million to build this pavilion. I have to say, as a psychiatrist, it did give me almost a small desire to move to Ohio, which I never thought about before, because they just have such an amazingly robust system. They have the ability to have people stay in like a crisis unit, like a family-based intervention. They have units that are like state of the art. They have juvenile justice programs. They have all these services, which is really quite extraordinary, but it is, I feel, a beacon of hope for me to know that, this is possible if we come together and kind of like spend the time and energy and support behind making children's mental health a priority. So I want to talk quickly kind of about what we're doing here in Maine and then answer questions and comments. So this is the logo for our partnership. It's called the Maine Pediatric and Behavioral Health Partnership. This is our mission, which is pretty self-explanatory, very similar to some of these other programs. Because it's really an initial program kind of to restart this coordination. Our goals are relatively limited in that we're really trying to provide trainings to primary care on different topics, provide access to mental health services in the community, and then to make sure that this program is sustained beyond 2023, which is when our funding for the current project ends. And as I said earlier, it's a collaboration between us, the Department of Health and Human Services, and Northern Lights. What it pays for currently, as far as Maine Health is concerned, it pays for a full-time project manager, Julie Carroll, who hopefully is on this call and is very instrumental in our work. It pays for a part of my time, and it pays for institutional support through those various people. And we have some deliverables, which is really about making trainings, recruiting providers into the partnership, figuring out how we're going to do telehealth, how we're going to get consultation to primary care. We are not able at this point to do phone consultation for the state, just because we don't have the bandwidth or the program set up. So it's asynchronous mainly. Luckily within Maine Health, we can do more synchronous, but the goal obviously would be have that to be available statewide. So there are challenges to setting up this program. And again, going back to the secret sauce, this I think is where the most important work has to be done. It is difficult to coordinate across different agencies and medical systems. It has nothing to do with which agencies, it's just complicated. Every system has their own paradigm, their own culture, and navigating that is taking a lot of time and energy. Not different to any other project like the Peace Corps that I've done this one, it just is very time consuming. Connecting with the rural clinics is challenging because they're not necessarily within a larger system. So we are starting our cohorts, both us and Northern Lights, kind of within our systems and kind of like thinking about how we can better enhance those programs. But really the second and third years of the grant is really going to be really more about how are we going to connect better to these other practices. Again, we have to be able to foster relationships with primary care so they feel comfortable. A lot of time and energy we've spent both within our department and with this grant thinking about how are we going to manage this co-management of cases so that people feel comfortable. It's hard to create these training tools and disseminate them to busy clinicians, really trying to drill down to like what's important and what will be useful. And then we have to think about funding and priorities going forward. So, and then it happened. So my point in this being that like we started this grant, we had this project, and then the pandemic. And so in some ways it's been helpful to us, and in other ways, obviously it's been quite challenging. The things that have been positive within Maine Health with this project is that we were able to move pretty quickly from having pretty limited communication as a department with primary care to being able to make this referral pool in Epic, which some of you use. The idea eventually is that we would use it really just for kind of consultation, quick questions. I mean, right now we're using it for everything, but it's really been helpful for us to be able to have conversations more with primary care and provide more quick response times. We've been able to triage cases more quickly. For those of you that have been doing referrals, you've noticed that we've instituted CGI, which is just really a way for us to get a quick understanding of how acute cases are. Telehealth went from like this long discussion about how we were going to manage it to being a reality in a matter of weeks, which is really awesome for us. So we're hoping that it will remain part of what we do. I have to say that it's not the same as having patients in person, but it certainly is helpful in situations where there's a lot of social determinants of health that are going to keep people from coming to see me. With the increase in anxiety, depression, isolation, suicide attempts, all the things that you all are seeing with pediatrics and adolescents, there is a greatly increased focus on mental health and the lack of services, which hopefully will lead to there being more support for our work in mental health care. And so really just hoping this will lead to real changes. And then this happened, which is what I am in currently, which is the EPIC integration of psychiatry into the system. So we're right in the midst of the rollout. Monday was our first day. I have to say that I'm hopeful, but I would like to kind of put this on your radar as pediatricians and family practice docs, that there's a lot that needs to be thought about. There's a lot that remains to be seen about how much communication is going to be allowed between primary care and psychiatry, whether we're going to be able to document into the chart. That's an active part of conversation, whether we're going to be able to change the problem lists, whether or not we're going to be able to allow access to our notes and evaluations for all of you. So pay attention. It will at least improve the ability for our primary care to contact us, and we are all at least on the same medical record. I am hopeful that we are going to be able to have more open access, which I think in its own way will help to decrease stigma. I mean, I personally would be happy to have patients access to my notes and be able to contact me, you know, if I ever have a nurse or an MA to help me to do that. We do have an MA, but he's spread thinly between all of us. But anyway, I mean, I'm hopeful that this will kind of start to move this part of the project forward, at least within Maine Health. So the current projects that we're working on, and then I'll take some time for questions within Maine Health. We're working on the training series, which started on Monday with the Children's Health Service Line. That will hopefully be also coordinated with the grant work. So to be able to be offered both within Maine Health and across the state. We're maintaining our referral pool and kind of like managing questions through that pool. We're trying to get data collection to get the right kinds of trainings to providers. And we are working on, once we can go in person, to do more targeted lunch and learns in collaboration with particular practices. We are working actively right now to do Project Core, which I'm sure you all will hear about or have heard about from the leadership within pediatrics. But we luckily are part of that initial rollout. We're very happy about that, to try to be more accessible to primary care, to provide more assistance in the moment. We're creating clinical guidelines through that project. The 5 that we've identified are anxiety, depression, ADHD, trauma, and aggression, as those are the most common concerns that we get. And then, of course, we're still doing some phone consultation within Maine Health. So with the grant and what we're doing kind of across the state, we're creating, again, training materials. We're trying to do these series across the state so any practice that can have access to them. We're working on recruitment of our outside cohorts outside of our 2 systems. We're identifying screening measures to put on the state website, doing some lunch and learns in collaboration with our partners, both within our particular cohorts and without, and then working on phone consultation. So lastly, we need you. We need you a lot in order to get this done. So we are really happy to be partnering with pediatrics, especially family practice also, and any specialty that's willing to work with us. We are a small department, so we really need all the help we can get to be doing this work. And I want to give a special shout out to the people listed below. Thank you for all your help and your care in working on this project. Hopefully we're back on just people.
Thanks so much, Amy. I'd like to open it up. It was a wonderful talk and such a needed part of pediatric care to enhance our ability to take care of children with mental health problems. I'd like to open it up to questions if anybody wants to put a question in the chat.
So I'm just gonna, looks like there's a lot of questions. I'll just probably start from the bottom and see what we can get through. So looks like Dr. Koppelman asked how they can access me. So you, or how you can access any of us. So you can, there is a smart phrase in EPIC currently that's a dot phrase called Pediatric Psychiatry Referral Questions. It's kind of based after the other referral questions for different specialties. So you can currently you can send us a question through there. It is based right now for referrals and for kind of a quick consult. Eventually, we are going to split those into 2 different pools for actual referrals to the department and then questions, but we're just not there yet because we had to kind of put it in place during the pandemic, excuse me. But you still can send questions there, and either I will see them or my other pediatric psychiatry colleagues, who are Dr. Gerwin currently and Dr. Nielsen and Dr. Bender. Well, one of the 4 of us will see those questions and hopefully get an answer back to you. Are there non-EPIC options? So we are working on that. That's kind of why the state project is so important. I mean, currently I do have pediatricians that access me through email, which is more difficult, obviously, because if I have 50 email, I may not see your email. You can always call the phone number on the referral line, and that will get to us eventually. This is, again, a part of the process that we're working out that's going to take some time. Okay, I'm trying to there's more questions coming as I try to go up. What do you say to the pediatrician who says that I didn't go into pediatrics to become a psychiatrist? Oh, John. That's from John Fanberg. That was part of my talk on Monday. So the unfortunate thing, I think, is that you all are going to have to do psychiatric care because there's just not enough of us to go around. And so that's kind of why we want to work so hard to help you do some of this work in primary care, just because it's going to be impossible for us to see every single patient. I think for our department currently, what we're trying to work on is seeing the most acute, complex kids in child psychiatry, and then getting to the point that we can help pediatrics manage more kind of garden variety care, how to do better diagnosis, how to do better evaluation, just because it's going to be impossible for us to see all of those patients.
Amy, there's a couple of questions that I can give you that are in the Q&A.
Okay.
One is from Kelly Bowden. What about screening mothers for postpartum depression during newborn well child visits? And then what do you do with the concerning screen result?
So I know that in adult psychiatry, they're doing some work around that. I have to say I'm not as involved in that work, but I know that that's happening. I think Robin's on this call too. She may be able to answer that a little bit better than I do. Robin, are you here? She may have left. Anyway, I can't speak specifically about that. I see you said yes. Can somebody unmute her so she can answer?
While we're waiting to unmute her, there's a couple of questions about how the educational components of the program that you're launching, how they relate to the current ECHO efforts and the e-consult type efforts.
Yeah, so I mean, the efforts that we're doing through the program are actually, at least for the Children's Health Service line, oh, I see Robin, she'll be on a second, are really, were identified by the Children's Health Service line in order to better help primary care. So that came directly from pediatrics. I'd say that the way that it's kind of interfacing with some of the other efforts, CORE, the ECHO we've been involved with previously. I think that we will continue to do support for them. Last year, we did work around the PHQ-9 and kind of screenings in primary care. But really, I feel all these efforts are interdigitated because we're really just trying to reach things from multiple different angles. The Project Core work is really around e-consults. And again, we're doing that with pediatrics to try to figure out how we in child psychiatry, some of the other specialties, GI and nephrology, can really better help manage more common conditions. I see Robin on. Do you want to talk a little bit about the postpartum, the work that they're doing?
Yeah, I don't have a great answer, but this is coming from different areas that have yet to be stitched together, and it might be an opportunity actually for the Children's Health Service line to coordinate these efforts. Because we're looking at screening women in OB clinics as well as well child. And Steve DiGiovanni has some relation to the effort too. So there is no coordinated plan right now. And then the other thing I'd add is that the referral curbside workflow that currently exists in EPIC for pediatric psychiatry referrals doesn't have an adult psychiatry component yet, and will eventually. So that the hope is that the e-consult model that we kind of pilot through child psychiatry and this referral pool question that you can send through EPIC will give us a model for how to do that when the patient is an adult, even if it's a pediatrician or family practice doc who's seeing the child of that adult and can still make a referral.
And I see that Steve DiGiovanni in the chat mentioned that the Maine Health ACEs team is also available to help with the EPDS work.
Yeah, I think that that's the great part about being involved with this project right now is that there's a lot of different groups that are kind of dedicating themselves to different parts of, the ACEs group, the postpartum group. There's just a lot of people that are really interested in kind of like helping children and families do better. And so, it's really rewarding, even though it's difficult work to do. And so, again, I just really want to thank pediatrics especially and the Children's Health Service Line and helping us with this work and kind of like moving the ball forward. Any other last questions or thoughts?
Well, thank you so much, Amy. It's wonderful to partner with you and Robin and Roz and others in child psychiatry. We think of you guys as just a subspecialty of pediatrics. So, and we desperately need your consultative and help and expertise. So thanks so much for giving an excellent grand rounds today and for your advocacy efforts to improve access.
Thank you. And I would say, Marion, to everyone else, all the pediatricians and everyone else that's on the call, including integrated clinicians, like this is obviously all a work in progress. And we're going to make mistakes, and there are going to be things that are clunky, and there's going to be things that need to be streamlined. And so we welcome feedback, and just hope to make this the best process we can.
Thanks, everyone. And hopefully everybody saw the code to claim CME that was shared. It's 34356. Again, 34356.